جميعا الأمسية معنا. We will start now our presentations session. So there is no better way to wrap up this workshop than exposing the experience of each one of the faculty. Tonight we have 4 eminent experts coming from different parts of the world. Let me introduce each one of them. First, Professor Zeng, who came from Guangzhou University in China. He's a world expert in endourology, especially mini-PERC and super mini-PERC, and he's doing also retrograde intrarenal surgery. And he showed us over the last couple of days different technique of achieving good results with different techniques. Especially we appreciated the technique of puncture under ultrasound and the super mini PCNL that handle stone even with the bigger size than what I thought previously is possible. The second guest is Dr. Sanjay Khadji. He's not here. I don't know. Where is Sanjay? Yeah, will come back? He'll
come back at his train room. 02028.
Okay, we come.
Yeah.
So Dr. Sanjay Khadji is a world expert in endourology and stone surgery. He's a regular faculty of endourology challenge, and he performed several cases, or maybe over that, in the thousands of cases of mPCNL. I had the opportunity to visit him in Nepal and see what he was doing, and I was very impressed by his capacity of dealing with whatever size of stone with this technique. Sanjay will present his Nepalese experience tonight, and fortunately he's not here yet. He will come soon. Dr. Shabir al-Musawi is from Kuwait, and I had the opportunity to work with him over several years, and I know him very well. He's not only in stone management, especially PCNL and laparoscopic surgery, and he is technique. Dr. Muhammad Azraq. Who doesn't know Muhammad Azraq? He's the father of modern endourology in Morocco. So Dr. Azraq is a school in himself. By himself, he's a school. So we are really very appreciative of coming here tonight to share your knowledge and experience. Okay, so I don't want to be too long, so we'll start the presentation with Professor Zeng from China. Welcome to you.
For Dr. Zeng gave me opportunity to come to Morocco for show my technique for a report. Yesterday and today I performed the 2 operations for super mini PCNL. Maybe I talk about again. I hope everybody like it, this technique. Compared to the flexible and the shockwave and the PCNL procedures, is too high stone flow, high complications such as bleeding, urosepsis, and so on. But how to decrease bleeding from PCNL procedures? Everyone must remember. Always make a puncture from thorax, level from infundibulum. Must. Yeah, this is the first. Because you make a puncture really from follics, only 80% value injury, no artery injury, no embolization, So good puncture, good PCNL procedures, and how to make a good puncture under fluoro. Traditionally, my teacher tell me you must learn bull and technique. I think this technique is useful and practical, but it's a long learning curve, more and off radiation. I can more easy and less radiation. This is modified bull technique. This is my technique with CM 0 degree, and the patient is frozen position. And the acupuncture is calyx, and the needle must over the target and the monitor. There is only two conditions, only three conditions. The first is hit the target. The second lead tip is anterior. The other is posterior. Only three possibilities. How to come for three conditions? Very easy. And you rotate CM X-ray 30 degree toward the surgeon. You sit, so surgeon sit here. You rotate the CM here 30 degree, and you 30 degree. There are three possibilities. The first ability is the no change, 0 degree and the 30 degree, no change. This is correct position. You make a good, make a perfect puncture. And the second, the needle tip is before the target. That means your needle is too anterior. It's before, you see, this is before. Wait later. You see, this is before the target, means your lead tip is anterior. You must adjust posterior. The puncture is okay. Yeah. And the first possibility, the lead tip is beyond the target, and then your needle is posterior. It's posterior. You must adjust your needle anterior. Yeah, it's very easy. But for me, I do too many. I only 0 degree is enough. Sometimes for very, very difficult case, small stones, I use this technique. Mostly, I only 0 degree is okay. But for neuro, you can use this technique. Very useful, very practical. And the second, how to decrease bleeding from PCNL procedures, I think small size axis is useful. And so different midi-poke technique was developed, such as micro-poke, ultra mini-poke, and my super mini-poke is different. Because the same aim is decrease the bleeding. But this small size axis can decrease bleeding, but new problem for this technique. Because small size axis must match small size endoscope. Very endoscope is working channel irrigation very small, and this low irrigation flow. And the very small exercise is very difficult to remove the stone fragments, and because low irrigation flow, then cause complete missed endoscopy view, and always use pressure pump. They maybe cause high intrarenal pressure. And how to deal with these all problems? We team in 2012 developed this first generation super mini PCNL technique. This is the first generation SMP system This is only 7 French and with 3.3 French telescope, and this suction is plastic suction. Sheath with suction. This plastic, and the exercise is 10 and 14 French. This paper was published in the BJUI in the last year. And with this small endoscope and with this suction sheath, and the 2 problems have been solved. You can fast remove the stone fragments, and with this suction, maybe a low pressure, and the low problems are not yet to be solved. Irrigation flow is really low, and the endoscopy way maybe is not good. Sometimes bleeding is not really well. Because irrigation channel is limited, and with this limited irrigation channel is limited irrigation flow. For example, for this SMP telescope, working channel is 3.3 French, and you short the 200 micron nasal fiber. Actually, this 200 micron nasal fiber real size is almost 200 micron. Everybody must remember. And how much space for this irrigation? For this for the fiber is 1.2 French, is only 2.1 French for irrigation. Small space must you increase, pump pressure increase, but irrigation flow is slow. You increase, flow is slow because we need more space for irrigation. How to manage this? We must change your mind. Yeah, traditional irrigation is from the working channel in the telescope, and you must change irrigation from scope system to the sheath system. Irrigation not from the telescope, it's from the sheath. It's change mind, then you change your technique. So I think new generation SMP system and irrigation, this irrigation suction system, I think it's real innovation for SMP. It's a revolution for mini pop technique. Okay, next introduce irrigation suction sheath system. This sheath consists of 2 parts: straight sheath, and the handle parts. Sheath consists of 2 layers. Metal sheath can form a very small gap in between for irrigation, and 8 or 10 holes is located at the tip of sheath for outflow. There is a vent in the handle parts. You can control the negative pressure is open or close. You can control very easy. Because sometimes you must increase negative pressure, you close. You can decrease open. It's very easy. Okay, actually this irrigation suction sheath is good in and irrigation flow, and the clear endoscopic view, and the more active the evacuation of stone fragments. Because this is a one-way suction. You see, this is a new system. This is a general system. This is irrigation flow sheath. You see, the sheath here and the suction here is one way, and this is the order. This order is irrigation from scope here and the suction here, and this fighting, two fighting, and then the stone fragment sometimes is back to the kidney again, and some is out. It's not effective. And now let me see this video.
distance on 8 French miniaturized nephroskop with a newly designed irrigation suction shoes. The irrigation suction shoes is composed of a straight shoes and a handle. The handle consists of an irrigation port, a straight tube, and an embolic 5 kg tube at 45 degrees. The suction port located at the end of the embolic tube. The straight shoes is 2-layered net structure. The space between the 2 layers of the shoes functions as a channel for the irrigation water, and the central element of the shoes works as conduit for continuous suction. The shoes have side holes at distal tip, which allow ingress of irrigation through the irrigation channel. The key feature of the irrigation suction shoes is to allow inflow and outflow respectively. The irrigation is delivered through the irrigation channel of the shoes. Thus, a one-way flow is created as the inflow that comes out of the irrigation channel of the shoes is immediately aspirated through the suction conduit of the shoes. The irrigation can create a vortex at this end of the shoes, and active suction can help to draw stone back into the suction conduit to label it. During the suction, the negative pressure can be adjusted by lowering or opening the pressure vent located in the access of embolic tube. Now we introduce the SMP technique in one case who had a 1.8 cm stone in left kidney. The patient was placed in prone position. Access to selective Calyceal with a treatment of guidance. The successful puncture was confirmed both by free flow of the irrigation fluid and by fluoroscopic images. Using a guide, the dilatation was carried out with a French facial dilator. Then, a 14 French irrigation suction straight shoes with an obturator was advanced over the guide wire and introduced into pelvic Calyceal system. After checking the position of the shoes under direct nephroskop operation, the guide wire was removed and the handle was connected to the straight shoes. The irrigation port of the shoes was connected to an irrigation pump. The embolic tube of the shoes was connected to the specimen collection bottle and the bottle end to the negative pressure aspirator. Stone fragmentation was accomplished by using Holman laser with 550 micrometer fiber. The tiny pulverized stone fragments would pass around the scope and evacuate through the embolic sluice. If the stone fragments were too large to pass around the scope inside the shoes, the scope could be withdrawn slowly to proximal to the bifurcation in order to create an unobstructed channel for large fragments evacuation. During the section, the negative pressure could be adjusted by either partially or completely occluding the pressure vent. At the end of the procedure, a single fluoroscopic imager was obtained to assess the stone-free status. After removing the urethral catheter and the shoes, the wound was sealed with absorbable gelatin. All stone fragments had been collected in the specimen collection bottle. One day after surgery, a CT scan confirmed the patient was stone-free, and the patient was discharged following the CT scan.
After video, I compare the fourth generation to new generation SMP. You see, this is some not different. It's the same. The new SMP telescope is little large, 18 French, and the old one is 7 French, and the work channel is the same, but it's high quality. And this is irrigation. Is here. It's one way. This is one way flow, and they improve the fragments irrigation. And this is the outcome of new and the old one. This is the old. In my center is 2006 last year, altogether for new SIP is 71, and the old one, old SMP is 43. Is the before operation is data is okay. It's the same. You see, it's only for new SMP is short time, for operation time is short. It's short, and the hospital stay is short. The complication and the stone flow is the same. It's the same. And sometimes this is pressure new is little high than old one. You see, the old one is almost 14, and the 14, and the new one is 20, but or less than 30 millimeters HD. Yeah, little higher because big flow is. And these basic requirements for best mini POC system is the old one, you see, is not good. The new one is good. Only little high pressure. Only little high pressure. And this is indication for SMP. What the old and new system is not for too large stone. It's only for less than maybe 2 or 3 centimeters, not too large. And the failed, shockwave and flexible, and especially for the pediatric patient with resistance to the shockwave, this is the indication, the best indication. And this is SMP for adult stone disease. For this case is solitary kidney, and the stone is local stone. Always remove the upper ureter, and then how to manage it. The first choice may be shockwave for flexible PCNL. My first choice is flexible. You see, the flexible, the stone is here. The stone is here. It's flexible, cannot raise it. Very difficult, very difficult. And how to do? I change it to the super mini SMP, 2 punctures. Total tubulus, no tube, no stent. And the second day, the patient go home. And this is 231 cases. Stone size is 2.3 centimeters. And the operation time is not too long, 44 minutes. And the 1 day after operation, stone flow is almost 90%. And the 3 months stone flow is almost 95%. And the patient is no bleeding, 0. Transfusion is 0. No patient needed blood transfusion. And the tubulus PCNL is almost 94%. Total tubulus, no tubular stent, is almost 64%. The second indication is SMP for pediatric little stone. This is 2 years old girl, is 2 centimeters right kidney stone, shockwave failure, and after operation, stone composition is cystole stone. For this cystole, maybe it's shockwave is difficult, and you see, make a puncture in the middle calyx. And I use pneumatical, not laser, you see. It's a pneumatical. This pneumatical, sometimes for SMP, you have low laser, you can use pneumatical, use chips. But you can use pneumatical prober, maybe only 1 centimeters or 0.8 centimeters, okay. The total tubulus, the children is no favor, the second day, you can go home. No standard, no tube. Yeah. And this paper was published in Journal of Endourology. This is almost 111 cases. And you see, the stone flow after 1 day is almost 91%. 3 months stone flow is almost that is 60%. And no children need transfusion, is 0. Yeah? Total tubule is almost 85%. This sum last year introduction was SMP liposolubase. This in Torino, Italy. This in Tokyo, Istanbul. This is Lazo hospital in Istanbul. This is Germany. This is Germany. This is Spain. This is Spain at Alicante. This is in UK, UCL. This is Lazo is Pakistan. Pakistan. This is in Indian Delhi. The last is in Philippines, Manila. And make a summary. As Professor Kemo Sarke, he is chairman of ULE, said SMP has a larger definition. S means safe, M means meaningful, P means practical. So SMP is a safe, meaningful, and a practical technique. Okay, last conclusion. New SMP solve all drawbacks in the mini-port, achieve an excellent clinical outcome, high stone flow, high total tubulus, and short stay, hospital stay, and less complication. 0 transfusion, so new SMP system must be best. Okay, thank you. Attention.
Do you want to take some questions from the audience concerning this technique? Sanjay, have any comments?
Sanjay?
No problem.
You can come.
Excellent.
Comment. Because you always do mini port, but you change it.
We've
Try
seen
it.
this morning that using only laser with this super mini. You use laser glass as well.
Actually, for laser, this you have laser machine. This laser is okay. It's better because laser is very powerful. But sometimes this laser machine is not available. You can use UMAC. This flow maybe 1 centimeters, 0.8 millimeters. It's okay. It's now. Yeah.
Do you use this technique in malformated kidneys like pelvic, horseshoe kidney, and so on?
For this, sometimes for this Horseshoe, this no problem. It's only focus the stone size. Size is less than 2.5 or 3 centimeters is enough. It's transplanting kidney, Horseshoe kidney is okay. No problem.
It can be done in any condition. Thank you very much, Professor Zeng. It's very kind of you for answering your question and being on time, concise, and practical and meaningful as your technique. Okay, we'll give now place to Dr. Sanjay.
To everyone, first of all, I would like to thank Dr. Zeng inviting me in this beautiful city, Morocco. It's really nice to be here in this beautiful city. Well, Nepal is situated in the southern Asia in between two giant countries, China and India. Well, Nepal is the place, the birthplace of Buddha and the peak of the world. Today, I'm going to share about the mini-PCNL technique. Well, I have been doing tubeless mini-perc for the last 6 years, and Professor Zeng is my teacher who taught me how to do mini-PCNL. And our relation is of 11 years, which is continued so smoothly as two brothers or two friends.
Great.
Well, this is the hospital where I'm working. It's a 50-bedded hospital in Kathmandu, Nepal. Well, as we all know, PCNL was introduced in 1976 and rapidly evolved into the gold standard for treatment of large and complex renal stones. Classically, PCNL concludes with the placement of nephrostomy tube based on the number of access made. Well, Mini was first introduced in 1997 using a smaller track by Jalal and group. Different urologists in the world modified this technique in their different way. So this may be the largest series of Professor Zeng published in the Journal of Endourology, the cases of 10,000. Well, today I'm going to highlight, as you have seen few cases, how we perform mini PCNL. I will be highlighting this using the different instruments and its advantages. Well, in this mini PCNL, we are using this miniature nephroscope or the short ureteroscope, whose size is 8.5 and 11.5, whose working channel is 6.5. Well, this is the telescope, and if you compare with the other treatment, Mini, you use a single table with the minimal instruments. As you can see here, as you have seen, we use simple step dilators up to 18 French in most of the cases. Well, once you place the guide wire, we can use these dilators simply in rotating fashion in the clockwise and anti-clockwise direction, which causes minimal trauma to the kidney. So we do not need to apply much force during the dilatation, which causes less trauma to the kidney. Well, very important is irrigation pump. As you have seen, this is the intermittent irrigation pump, which is connected on the side of the ureteroscope, which gives the intermittent flow. It gives a water flow for 2 seconds and stop for 1 second, as you can see here. The main advantage of using this irrigation pump is it gives a clear vision during the procedure. Number 2, see, as you can see here, it gives a clear vision. This is a video taken with a single chip camera. Once the stones are fragmented into multiple small pieces, about 3 to 4 mm of size, then we intermittently remove this telescope from the working sheet. And these fragmented stones are removed very rapidly. Even the stone size of 15 mm or 20 mm can be removed within few minutes, as you have observed this afternoon. Many urologists are concerned about the safety of the irrigation pump. As we all know, threshold of safety is 40.8 centimeter S2, but with the use of mini PCNL, it ranges up to 5.5 to 18 centimeter S2, and together with the ureteric catheter, it goes up to 34 centimeter S2. As you see here, if the pressure is above 40.8 centimeter S2, there is a chance of pyovenous pyolymphatic backflow, which causes sepsis. But it is completely safe to use this irrigation pump, and this is a paper by Professor Zeng with the use of 15, 14, 16, 18 and double 16 French. The pressure is 24, 16, 11 and 5.8. The message is, smaller the tract of the size, the high pressure. If you make a multiple tracts, the pressure becomes less. As we all know, kidney is a compact system. Once you make a tract, this system becomes open and pressure becomes generally low. Well, as I told you that our puncture, about 70% of our cases are through the middle calyx, but it varies from patient to patient and also depends upon the stone location. Usually, it goes in between 11th and 12th, and about 1 centimeter medially from the tip up to 12 rib from the upper border. Well, generally, we choose the isolated calyx so that you do not go through and through the different calyceal system and there is a less bleeding. If you choose the isolated one single calyx, if you could go through the fornix, there is a very less chance of bleeding. Well, we do not prefer this angulated system with the sagittal plane. We prefer, as you can see here, we prefer lesser angle of the tract so that stone evacuation is much faster. As you can see here, when we go to the superior calyx, the angle of the tract is much higher and stone with this irrigation pump removing is more difficult. See, if you use this mini PCNL, any bulk of stone can be removed with this mini PCNL. Many urologists in the world have considered that mini PCNL is only for the small stones, that is less than 2 centimeters of size. What I would say is, if we have a good expertise and good instruments, proper instruments, any bulk of stone can be removed with the mini PCNL technique. As you see here, huge bulk of stone in the kidney. This was the patient done in 2006 by Professor Zeng in Kathmandu, Nepal. This we have done in 2 stages. In the final second stage, we could remove completely. The next advantage is when we perform mini PCNL, it minimizes multiple tracts. Well, many people, they talk about the mini PCNL, it decreases only bleeding. It's not that, not only that, another added advantage is it minimizes multiple tracts. These are the stones of previous X-ray. Not only that, if you see that even complex renal stones, this is a picture of 17 years female patient, right, who had a bilateral renal stone. I performed on the right side first, and second stage on the left side with the 3 tracts and 2 wide tracts, total of 5 tracts, with the complete clearance of the stone. So how it minimizes multiple tracts, as you have seen this afternoon also. Usually we go through the middle calyx. When we go through the middle calyx, it acts as a neutral position. We can swing our telescope up in the superior calyx and down in the lower calyx. Not only that, when we go through the middle calyx, it forms a straight alignment to the upper ureter, and you can go down up to the L4, L5 level. Even for the upper ureteric stone, more than 10 mm size, I prefer to do mini PCNL rather than RARS or URS, because our patient, they want complete stone clearance in one stage. They do not want multiple stage surgery. Another important is, once we disintegrated stone into multiple pieces, we can advance this sheet close to the stone in different calyceal system. This is very important tip. If you keep the sheet tip and the stone at distance, you cannot remove these stones very easily. Important is, you should advance the sheet close to the stone. It forms a compact system and stone evacuation is much faster. Right? How it minimizes multiple tracts. Even when we go through the lower calyx, you can advance this telescope in different calyceal system. Not only that, even the narrow infundibulum like this, you can advance your telescope. This is possible with this semi-rigid. If you use nephroscope, this maneuver is not possible. You can even check in the parallel calyx, also in some part of the upper ureter. Well, what do you think, Dr. Zeng? Can you pass a telescope? flexible in the superior calyx.
And now you can steer into the kidney as a driver.
See, even in such angulated system, you can pass a ureteroscope gradually. But this is done under vision. Under endovision, if there is any resistance, you do not advise to advance the telescope. So this is the beauty of mini PCNL. You can minimize multiple tracks using this small caliber of scope. Well, I have been doing tubeless mini PCNL for last 6 years. We do not keep nephrostomy tube unless there is a pyonephrosis. Even if the patient have to have a second loop, I make another fresh puncture. We do not keep nephrostomy tube. This is the case with the 5 tracks, 3 tracks and 2 wide tracks. So what the literature says, if you make a multiple tracks, when you perform a PCNL, one must keep a nephrostomy tube. But we do keep double J stent. So this is a challenging case, single kidney, 45 years male patient who underwent nephrectomy some 10 years back, and he had a huge Staghorn stone, and this patient had a stenting in the heart whose ejection fraction was only 25%. We did mini PCNL in 3 hours, and next day we had taken CT scan. There was not even 1 mm stone left in the X-ray. So another challenging case, multiple Calyceal stone. The average size is 1 to 1.5 centimeter, and we perform mini PCNL with the complete clearance. This is a picture of young girl, 14 years, bilateral renal stone, and a long ureteric stone of 6 centimeter. So mini PCNL can be performed also in the anomalous kidneys. Like this, it's a horseshoe kidney who underwent mini PCNL with the complete clearance. This is the case with pelvic kidney stone, who had a pyelolithotomy some 10 years back and had a recurrence of stone. We performed this mini PCNL under spinal anesthesia in supine position. And there is a complete clearance. These are some of the challenging cases who underwent, who had a bilateral PUJ stone, underwent bilateral few sessions of dialysis, who referred to me for bilateral mini PCNL. This patient underwent bilateral mini PCNL under spinal anesthesia. This is another challenging case with the kyphoscoliotic with the bilateral renal stone. It was a very challenging case. If you see how we had to work hard to keep the bolster so that the patient is comfortable in epidural anesthesia, we perform mini PCNL bilaterally in single stage with the complete clearance. These are some of the obese patients from Nepal who underwent mini PCNL, and youngest child I have done bilaterally is 1.5 years with the mini PCNL technique. So certainly there are some complications. This bleeding, people are fear of doing PCNL because of this bleeding. But if we make a accurate puncture, if we are very precise, and we don't have to worry for this. So far I had to do 7 cases of angiographic embolisation, and this type of pleural injury we can expect, but within few weeks this recovery takes place. We don't have to do place a chest tube drainage. In my practice, I had one colonic injury in horseshoe kidney. That was just with a needle prick. That was not employed even in the Staghorn, horseshoe and ectopic kidneys. It is cost effective, short hospital stay and less pain. These are some of the renowned international urologists, De La Rosette, Sven Lamy from Germany. I had been invited in Paris for several times, even for the live surgeries. These are the pictures taken in Paris and Turkey. This was the picture from Amsterdam. If you see the theater, it's a world-class theater. See? Everywhere monitor, ultrasound, flexible, and their instruments are full of 3 or 4 tables to perform one PCNL. But this is not enough. The important is the surgeon who is operating, right? I hope you all agree with me. We use just one table. Yeah? I have seen whole surrounding the patient was full of instruments to perform PCNL. Right? These are the few fellows who had visited my center in Nepal for the training. And Dr. Archer Smith, he invited me in PCNL course as a faculty last year. And these are my 2 brothers from China. This is Professor Chou, who is a very famous in China, who does uro-oncology procedure, who introduced me Professor Zeng in 2004. So once again, this is the picture taken in Nepal with Dr. Zeng while visited in Nepal. Well, thank you so much, and you are welcome to Nepal.
Excellent, as usual, Sanjay. Yeah?
So you want to take some question?
Please, no.
Yeah. Any question from the audience for Dr. Sanjay? Okay. So I saw Dr. Sanjay performing this technique. I spent a week with him in Kathmandu and Dangareh, and we've seen what he can do with the mini PCNL. In every case, whatever the size of the stone, whatever the location of it. For me, Sanjay is a master and a Formula 1 driver into the kidney.
Thank you so much.